Why does my wound vac hurt? That is something I rarely hear because so used to dealing with patients who have compromised protective sensation, rarely think about that actually negative pressure wound therapy is a wound vac is actually quite painful for patients who have really good protective sensation. So, welcome back to Diabetic Foot Files, the podcast where wounds tell their story, science meets practice, and every limb is worth saving. So, today's episode, we're going to tackle a subject that every wound care clinician has encountered, but many patients are actually afraid to discuss. Why does my wound back hurt? The negative pressure wound therapy device, commonly called a wound vac. So it has revolutionized wound healing. I have been without one for over a year because I was in a developing country for about over a year and you had to pay out of pocket for that? So I was able to learn that, you know, I I had to be without it, but I like I said, I was asking for one. I was asking for one. I was even trying to get one for charity. Yeah, didn't, but, in the end, we were able to close it. But wound vacs work amazing. I like them, but, they are very expensive and, it's kinda interesting. I really liked what Dr. Chow said about the wound vacs. The whole reason I started giving patients my number was because of the wound vac because I'll never forget, finally had a weekend off, and then you have morning, and you have to round in the morning, like Monday morning, and one of my patients, their wound vac was off, and I was just like, What happened?" And it was just 2 different stories. The front desk was saying something, the nurses were saying something, the patient was saying something. And, like, we had to start it from ground zero again. And so that's the first time I gave a patient my number because I wanted to know exactly what is happening as they contact me, if it ever beeps or anything like that, so I can contact the right people. If I'm not there, like, contact the nurses to change it or fix the beep. And if there's a leak, things like that, okay? And that's why I started giving my patients my number because everybody was telling a different story, and no matter what, I just wanted to figure out exactly what happened and how do we avoid it from happening again. So that's usually why I give my patients my number, but now because we deal with high risk patients, I definitely always need them to have my number because I just want them to contact me immediately if something happens, if there is a pain that comes out of nowhere. Yeah, because these are limb threatening and like we said, things can turn left any second, okay? I mean, I do know eventually I probably have to get it like a second phone, right? But so wound vacs are amazing. They can shrink wounds faster, they reduce edema, they improve granulation formation tissue, they decrease bacterial not burden, and they help save limbs that once could have been required to have an amputation, but yet there's a paradox with it. So, a therapy designed to heal can sometimes become one of the most painful parts of a patient's journey. So, patients may tolerate debridements well, they may tolerate antibiotics well, they may tolerate surgeries well, but some patients actually dread one thing above all else is a wound vac dressing, okay? Sometimes wound vac dressings are quite painful. So today we're going to explain why the wound vac can cause the patient pain, so which patients are more vulnerable to this pain, the physiology of the vac associated pain, the pharmacology, non-pharmacological interventions, special considerations for our diabetic ulcers, and so forth, okay? So the great wound vac contradiction. I said contraindication. So used to saying contraindications and indications. So imagine this. You have a diabetic foot ulcer, the infection is under control. The surgeon performed an excellent debridement. Bellissima. Bellissimo. I don't know. Granulation tissue is beginning to appear and the vac is placed and everything is going perfectly. And then 3 days later, the wound vac dressing is removed and the patient screams. Why? Because the wound vac pain is not often caused by the machine, but it does is a therapy device, but it's caused by what the therapy does to the wound itself, okay? So how does a wound vac work? We already went through this in like last year sometime, okay? Because I love me a wound vac when I have it available. But if I don't have it available, the body is able to heal itself quite well. Your body has the building blocks to close that big deficit, to be honest, if you don't have it. So don't ever have fear or doubt. Your body, with the right conditions, your body's able to close itself pretty well. Okay. So how does a wound vac work? It is a negative pressure wound therapy device that is has applied controlled suction to the wound. So the system consists of foam or gauze, right? Occlusive dressing, tubing, and a vacuum pump. And the pump generates negative pressure. And this negative pressure creates fluid removal, edema reduction, improved perfusion actually as well, mechanical stimulation, as well as increased granulation tissue formation. So think of this like a microscopic workout for the cells. The wound is continuously stimulated to heal. And but the stimulation actually does activate pain pathways as well. So let's understand some of the pain pathways. So pain originates from these specialized receptors called nociceptors, okay? Nociceptors, okay? Nociceptors. And these receptors detect mechanical injury, temperature changes, and chemical irritation. And after debridement, wounds become very rich in inflammatory mediators, prostaglandins, histamine, bradykinin, and cytokines. And these chemicals sensitize the nerves. And now, even with mild stimulation, it becomes quite painful. And this is called peripheral sensitization. And the wound that normally would not hurt suddenly becomes exquisitely sensitive. And when the wound vac foam has contact with the tissue, it can develop pain. So why does the wound dressing hurt so much? So the biggest culprit is not the suction, it's mostly the foam adherence. And as granulation tissue continues to grow, right? That's what we want. So beautiful. Tiny blood vessels grow into the foam, but I want the blood vessels to grow, but not into the foam, right? But also tiny nerves endings grow into the foam. And then when the dressing change occurs, we have to pull the foam off away from the healing tissue. And that's why you see this nice bleeding granulation tissue. So imagine Velcro attached to the skin. And now imagine thousands of microscopic Velcro hooks attached to these fragile capillaries. And then that's what the dressing removal feels like. So there are about four types of wound vac pain. Okay. Type one is placement pain. So that occurs during the initial application, like you have a fresh surgical wound, exposed tissue, manipulation, because it does require a lot of creativity to put on a wound vac. Okay. It literally is like arts and crafts. Type 2 is continuous therapy pain. So causes of that usually occurs while the suction is running. So causes are tissue deformation, mechanical stress, ischemic sensitivity. Type 3 is dressing change pain. So that is quite the most common one, most severe and the most feared, okay? And then type 4 is rebound pain that occurs after the wound vac removal, usually related to tissue inflammation, nerve exposure, and dressing trauma. And diabetic patients are very different because, you know, we're so used to our patients having their protective sensation compromised and this extreme numbness where they feel no pain. But that is a big assumption still. That is a mistake that sometimes we make because clinicians assume neuropathy means no pain. And that's a very dangerous way of thinking. Patients with diabetic neuropathy can still experience deep tissue pain, infection pain, ischemic pain, bone pain, and many report I can't feel my toes because but the wound vac hurts. Okay, so because different nerve fibers transmit different sensations, so neuropathy is not complete anesthesia. So keep that in mind for your patients. Okay, so When the VAC pain signals trouble, pain is not always so bad, but sometimes pain is inflammation. So, sudden severe back pain may indicate a new infection, may indicate an abscess formation, may indicate ischemia, may indicate bleeding, may indicate exposed tendon, may indicate exposed nerve, may indicate improper foam placement. Never assume increasing pain is normal. Increasing pain deserves investigation always. Okay. I always tell people do not underestimate a patient's pain. Never do. It always gets the person in trouble. I'm just saying that's from my experience. It always gets the person in trouble if they downplay a patient's pain. Okay. Now, pain medications, oral medications. The simplest intervention is pre-medication. Pre-medication, medication before we administer the dressing change, right? So like 30 to 60 minutes before. So options include acetaminophen, which is used for mild pain, minimal bleeding risk. So NSAIDs. NSAIDs are very helpful for inflammatory, but they increase your bleeding risk, right? Like ibuprofen, naproxen, and also you have to cautiously use it in patients who have renal disease. So keep that in mind. I would just get pain management on board. Now, opioids. Everybody knows yes, I can prescribe opioids, but I just do not. Okay, so things like oxycodone, hydrocodone, morphine reserved for moderate to severe pain. If my patient's feeling that, I do call pain management, internal medicine. I think they're the best ones to handle that because I just don't like prescribing opioids. That's my preference, okay? Often administered before dressing changes. I have had to do it a few times. I have to order morphine before a dressing change, especially the patients. Because the people have to remember there are patients who have really good sensation, and wound vac dressings are extremely painful for those patients who have really great sensation. And if they're in extreme amount of pain, first of all, it's traumatizing to them. You have to remember your body has a response when they're in pain and stress, right? So that's not healthy for the healing of the wound anyway. And then it's going to be really hard to dress that patient in peace because they can't stay still. They're in a lot of pain. So you have to keep those things in mind because sometimes they do need to get pre-medicated with something stronger like an opioid. Okay. But make sure you talk to their internal medicine doctor, think about their clearance, things like that. And forgive me. Okay. So topical pain control. This is where wound care can get a little interesting. Topical agents can dramatically reduce the discomfort like lidocaine gel. But remember, we did an episode on lidocaine gel. Sometimes people overdo it. You can overdose on lidocaine gel, okay? Can be applied before the dressing. Removal allows quiet nerves to quiet down, okay? Topical aesthetic solutions. So some clinicians instill aesthetic into the foam before removal. So the solution infiltrates the dressing and this reduces the tissue adherence and the removal can become significantly less painful for the patient. So one is I haven't used it, a saline soak trick. So one of the most cost-effective, low-cost interventions is before removing the foam, instill saline and wait for 15 to 30 minutes. And that benefit is it softens the foam, it loosens the adherence, it reduces tissue trauma, and it reduces bleeding. And many experienced wound nurses swear by this technique, okay? Works very well. That's why I love you, wound care nurses. I learned so much from wound care nurses, okay? Okay, now contact later. Modern wound care often uses silicone interfaces, non-adherent contact layers, and they're placed in between the wound bed and the foam. Benefits are less tissue ingrowth, less nerve stimulation, sorry, and less pain. But this is particularly valuable for our tendon exposure, our bone exposure, and our painful wounds. Now, continuous versus intermittent therapy, okay? So, as we all know, wound vacs operate in different modes. Continuous means it is a steady suction, often less painful and preferred initially. Now, intermittent these pressure cycles are on and off. They can improve the granulation, but often can increase the pain, and patients with severe pain frequently tolerate continuous mode much better. Now, another thing is they sometimes do regional anesthesia for very severe cases. So For severe cases, especially large wounds, extensive debridements, limb salvage procedures, options include like an ankle block, which is ideal for diabetic foot wounds. Popliteal blocks is excellent for larger wounds. Peripheral nerve catheters can provide prolonged anesthesia. These techniques can transform the patient's experience. Now, another thing we have to think about is the psychological pain. Pain is purely not just physical, right? Anxiety amplifies pain, fear amplifies pain, anticipation amplifies pain. Patients who experience one traumatic dressing change may become fearful of every future change. So this creates a pain anxiety cycle for the patient, and we have to break this cycle to help improve our outcome. And that is why communication is so important. The best pain medication may be communication, explaining what it will happen, why it hurts, how long will the pain last, and what interventions are available. Because then the patient feels more in control, right? Autonomy, right? And the patient who knows exactly what to expect, how often, and what to tolerate, and how when it gets better, right? So there are emerging technologies. There are new pressure wound therapy devices, right? Negative pressure wound therapy devices, systems that are developed with softer foams, silicone based materials, lower pressure settings, and smart pressure adjustments as well. And the future goal is simple, maintaining healing benefits while reducing the patient's suffering. So let's do a quick real case scenario. Imagine a patient with diabetes, osteomyelitis had a partial ray resection. The VAC is working beautifully. Granulation tissue is flourishing. That is what I want. But every dressing changes becomes quite severe for the patient. Pain. The patient says, take the VAC off. I can't do it anymore. At that moment, the wound care team has two choices: ignore the pain, or what do we do? Ignore the pain or pretty much address it, right? The thoughtful plan would be including pre-medication, saline soaking, silicone interface, continuous mode, anxiety reduction, and topical anesthetic. And suddenly the patient tolerates the therapy much better. So healing continues, the limb is saved, and sometimes the salvage is not just about the surgery, sometimes it's about pain control. So we have to remember that. So, the negative pressure wound therapy device is one of the greatest advances in modern wound care, okay? But healing does not require unnecessary suffering, should never be included, right? And pain during a wound vac is quite common. Pain during wound vaccinations is to be expected. Pain should never be ignored. And when clinicians understand the mechanism of the pain, proactively manage it, the patient becomes more compliant, actually. Okay. Patients just want to feel heard. Okay. And that's the fact. Okay. Because if you were a patient, you want to be heard. You want to have autonomy. You want to have a say. You want to know that these people care about you, right? And wounds heal more effectively, okay? And limb salvage rates improve. So remember, a wound that heals but leaves the patient traumatized is not optimal care. So we have to always remember that the goal is simply not just to close the wound, but the goal is to heal the patient with dignity, comfort, and trust. And this has been Diabetic Foot Files, because every wound has a story. Every limb deserves a chance to be saved. And sometimes the difference between saving a foot and losing one is simply as simple as pretty much controlling the pain that comes with the healing. This is Dr. G, and take care of your feet because they take care of you.